Good afternoon, everybody. Sorry that we don't have a live condition cases. It was not possible, so we decided to choose maybe more interesting or challenging cases in our department. We have performed, so I'll start briefly with the history. It's a rupture, basilar mid-basilar aneurysm, very hairy condition. You see it's like a dissecting aneurysm in which we decided to treat it in acute phase with this new P48 stent with coating. It's called HPC, hydrophilic coating, which allowed us to put the patient under only mono antiplatelet therapy. So this is the images from the procedure. Intraarterial DCA, we saw the wide-necked, like I said, basilar mid aneurysm. And because it's acutely ruptured, we gelled a microcatheter inside with the idea to put several coils just to induce faster thrombosis inside and to feel more safe about the next days and to prevent maybe acutely re-rupture of the aneurysm. So this is the navigation inside with the first microcatheter. This is already, you can see on non-subtracting images without the roadmap. This is the navigation with the second microcatheter with which we can deploy the flow diverter. Like I said, it's P48 flow diverter with HPC coating. We load the patient before the procedure, so 1 hour before the anesthesia. We load the patient with 50 milligrams of prasugrel. So we start the procedure. This is the navigation. We go for the left PCA because the anatomic variation was easier to navigate. So the next step is delivering the stent inside the microcatheter. If I remember correctly, it was Phenom 21, the catheter we used for the, I didn't mention the P48 stents coming through a 021 catheter. So this is delivering of the stent. Like you see, we just halfly unsheath some portion of the coil. So the first microcatheter traumatic inside the aneurysm if there is any intrusion between the two micros. So here is the tip. You can see it on the non-subtracting images above. Here is the tip of the stent. The stent is still inside the microcatheter. So here we are placing the landing zone we desire. So we can cover completely the aneurysm neck. It was very wide-necked. I think it's around 10 millimeters. The stent is 18. So we have to be very precise to have 4 millimeters above and 4 distal and 4 millimeters proximal to the aneurysm. You can see it's very radio-packed, it's very nice seen. So we here reach, if you can see, the point of no return to the stent. This stent could be resheathed at around 70 to 80% of its length. So we stop here, we start to coil. I didn't deliver completely the stent, so I didn't want to move it or to dislodge it during the coiling. So I decided now to put the first coil. Like you see, I didn't like the projection of the first coil where it was going like a mid-basilar, so I tried to play with it. I used the protection of the halfly sheeted stent. It's like a temporary stent for your coiling. So we are very carefully, very gently, just one long coil, and we decided to not waste time to stay with this halfly deployed stent. After the first
this is a 3D coil?
Sorry?
This is a 3D coil or a helical?
It's 360 of Stryker, I think. The longest they have is 50 centimeters. That's why we chose it. Not to lose time to deploy another one and to coil it. So when I was satisfied with the position of the coil, I detach it. And you will see very nicely how when you just push the stent from the point of no return, it perfectly applied to the basilar mid artery. I lied to you. There is a second coil. Sorry about that. I forgot it. We do, like the professor said in his presentation, loose coiling here. We have a flow diverter stent. We just want to reduce the chance of earlier rupture of the aneurysm. So here we're starting to deploy the stent. removing first the microcatheter for the coiling. And now we are ready to deploy fully the stent. And then look, you can see it above. It's perfectly applied, just covering the neck of the aneurysm. So we're going to do a final run to see everything is in place and at the desired positions. This is the removal of the wire of the stent. I didn't want to go through the stent here because I like the positioning to the wall. I didn't want to change something of the structure of the stent. And this is the final result with, I said, very good stagnation of contrast with the coil. So it was one of our first cases in which we introduced the stent with the HPC coating in an acute phase. So thank you for that. I think we are still in the time frame because I have 3 more recorded cases. The first case is a juvenile giant aneurysm of 19-year-old boy with just neurological intact with headaches. This is the anatomy of the aneurysm. Like you can see, it's a very nasty aneurysm. It's like dissecting M1 segment. These are the DSA runs during the diagnostics. So there is no option for a classical surgery here. We spoke with the boy and the relatives, and we decided to go for the endovascular treatment, in which our strategy was to put a flow diverter stent from the healthy portion of the M2 segment and not to cover the A1 origin. So we have to finish just before the origin of the A1 segment. For this purpose, I think the best stent available on the market is the P64 stent. Like you know, it's completely resheathable. You can deliver it completely, fully, and it's with at the proximal there is 8 markers. They're gathered together. So when you decided this is your position, you can just detach it. So in this case, you will see we have to put several positioning of the stent until we were satisfied with the positioning of it. It's a very long lesion. We have the same strategy here. We gel the first catheter just to put several coils inside and to induce faster thrombosis. And this here is the microcatheter for the stent. We go to the healthy M2 portion of the left MCA. We used 4.5 by 27. It's a very, very long stent, but we really want to cover it correctly. And like I will repeat myself, we didn't want intentionally to cover the A1 origin of the left ACA. So here is coming the second microcatheter, I think, for the coiling. We didn't use a distal access catheter. It's a young boy, so we used 6 French chaperone, I think, here, the petrosal sinus, the petrosal segment. If I remember correctly, we use most likely the echelon microcatheter for the coiling, and here is XT27, headway XT27 for the delivering of the flow diverter stent. So we are going with the wire inside the aneurysm sac, and just leave it here for the coils. It's very easy when you have biplane because you can orientate yourself for more things even during the navigation. So you can see here the first coil. We will halfly deploy it. Like you see, without any protection, the coil will penetrate or contribute inside the parent artery. So we leave it like that to be less traumatic. Without the roadmap below, you can see the delivery of the stent. Again, there is a tip. After like 5 to 10 millimeters behind, 5 millimeters behind the tip, there is the actual stent inside. So we are not much experience compared to Professor Henkes. So I cannot guess where, if it's unconstructed inside the catheter, where should I start with the with the stent, so to be completely sure where I will finish. On Thursday, we performed case together with the professor. He taught me some tips and tricks where should I observe and watch inside the microcatheter, so I can guess almost correctly where you finish. But I won't share it with you. It's only for me. So here we unsheath the stent. I will start slowly retract the microcatheter while holding the stent in place. Can you see it correctly? Okay. So here is the wire of the stent. And now it's starting to come the stent itself. You can see it's very nicely opened. So we just continue. This P64 stent has additional wire around it, which is very nice radio packed, and you can see is it a good well opened, is a good position of the wall. On the lateral view, the right monitor, you can see how it's stay inside the M2 segments. So here was our first try. We have like 10 millimeters more to the A1 segment, so I decided to resheath completely the stent and to try to go more proximally. It's really a beauty with this stent when you are not very experienced physicians, because if you don't like the position, if it's not open, at least you can remove it safely. But the best thing, you can resheath it or deploy it up to 3 times. The company says up to 3 times it should be safe. So I go a little bit more proximally this time. You can see it here. Here is the end of the stent. So here is the A1. I have 5 millimeters more. So I was maybe more aggressive this day. I decided to resheath it again and to go 5 millimeters more proximally for perfect wall positioning and more stability in the M1 segment. So again, I go a little bit more proximally, and it's completely delivering of the stent. Now we were satisfied with the position. I point you with the laser where these 8 markers are together. So now you just unleash it from their hypertube, and then these markers will become 8. So this means the stent is completely open. Before that, I finished with the coil. I was prepared for the sac. Here is still did not detach the stent. Here you can see the markers are still at once. Here is on the lateral view. So I just put one coil, I think it was one coil, remove the catheter, so I didn't want to change something with the already deployed stent. Then I detach it. So we now remove the microcatheter for the coiling. And now is the time to see these markers becoming 8. Here. You see the stent? Just do some tension, and the stent is opened. It becomes like a sleeve. On the lateral view, you can see it here. You see it? The markers. So they are completely opened for the nominal of the vessel stent. Now we are removing the wire. the delivery wire, do a final run, and we have 6 months, I think, and 9-month control for these patients with complete occlusion of the aneurysm. Very nice reconstruction of the stent, of the vessel. So now you see the final run. Very good stagnation, this ugly looking aneurysm. And I put several images, now you see it, the next one, from the first control on the first month, on the 6 months. This is complete reconstructions of the vessels. Very nice, with no filling inside the sac. So that was the second case. Thank you once again. Is there any questions about the recorded cases? Okay, thank you. Have a nice lunch.